Here we have CT of the abdomen and pelvis in 75-year-old female with history of acute abdominal pain with suspicion of a bowel obstruction. So what I am trying to show here is this incidental finding in the left side of the retroperitoneum in the region of the left adrenal gland. What we see here is a well-defined ovoid-shaped homogeneous low attenuation area. We can take measurement in its transverse, in its AP, and on the coronal reconstruction craniocaudal axis measurements. The most important bit is to measure the Hounsfield units, which is minus 75 Hounsfield units in this case. There are no solid components. There is playing of the limbs of the adrenal gland, and there is no solid component, and the margins are thin, smooth, and hardly measurable. There is no internal calcification, no evidence of internal hemorrhage. The right adrenal gland appears normal. Hence, the findings are in favor of an incidentaloma. So this is fat containing adrenal lesion. So hence, this is characteristic of adrenal myelolipoma. Most of the time, the adrenal myelolipomas are incidental, but sometimes they present with acute pain due to hemorrhage. In 10% of the people, adrenal myelolipomas are associated with congenital adrenal hyperplasia, in which case the other adrenal is usually enlarged. Here, the right adrenal is normal and the patient is 75-year-old with no evidence of any symptoms or signs of syndromes associated with congenital adrenal hyperplasia. Hence, the finding of myelolipoma is incidental and hence do not have any clinical significance. To summarize the clinical importance of myelolipoma, as I mentioned, 10% of the patients with myelolipoma have congenital adrenal hyperplasia, in which case we need to look at the other adrenal to see if there is another myelolipoma or there is a hypertrophy of the other adrenal gland. The non-functioning incidental myelolipomas have slightly higher incidence of Cushing syndrome, Conn syndrome, and sometimes there can be extra adrenal location of myelolipomas. Most important point to remember is there is no risk of malignant transformation of myelolipoma. Hence, once the diagnosis is proven on CT and/or MRI, there is no need for any follow-up CT or MR imaging. However, if the tumor is located at slightly odd locations and showing slightly odd characteristics, and if it's difficult to demarcate between the kidney and the adrenal, it throws few differentials such as retroperitoneal liposarcoma, fat-containing adrenocortical carcinoma, lipid-rich adrenal adenoma, adrenal teratoma, renal angiomyolipoma, adrenal angiomyolipoma, adrenal lipoma, or extraadrenal myelolipoma. So these are the differentials to be considered, but there is no need to provide all these differentials if the findings are very typical, as we are seeing in this case. So in summary, here is a nice incidental myelolipoma, which is of no clinical significance.